Working with the myofascia around the face and the head. I want to point to some areas where you'll consistently do very useful work and relieve a lot of tension that quite often isn't in people's awareness. It's one of those interesting areas where you'll notice that as you're doing the work, that people will often report that it feels very good and it's relieving some very long-standing tensions, but many times these tensions are ones that they hadn't had a strong awareness of prior to you working there. Want to also include in our work around the face and the jaw, that aspect of the jaw that's the work done intraorally. So work as I do in my clinic, tend to clear the more surface or superficial external restrictions, work through those, and then work on into the intraoral structures, and that's how we'll proceed today. The first contact will be on the masseters, and this is the superficial portion, and when I'm working inside the mouth I'll show some ways to work with the deeper portion of the masseter. I'm working bilaterally, but I'll just draw attention to this hand that you're able to see easily. I'm going to just locate, be confident about where the temporal bone is here, just anterior of the ear, and its contribution to the zygomatic arch, going across to the zygoma. So that whole arch is an important area to understand and to work with. But I'm going to take 3 fingers, so leaving the little finger out of it, just anterior of the TMJ, which is just anterior again of the external auditory meatus there. I'm going to take my 3 fingers and land down onto the periosteum here, and that's easy to do because there's not a lot of muscle and tissue at this point, so I can feel all of those layers of tissue as well as the underlying periosteum. I'll take up a tension and start to then put that line of tension going down towards the angle of the mandible. And here again, I'd like to just draw attention to the possibility that even though there's not a lot of body movement happening for me, nevertheless, I have a sense that my body's engaged in the movement of my fingers here, and that my fingers therefore have much more the role of the sensors. They're sensing as well as being engaged in the contact, but they're also getting a lot of feedback about what I'm up to here. When I get to the mandible, I'm continuing to develop a line of tension, this time with a lot of attention to the the line of the mandible itself. So, and that's again on the periosteum. It's not a deep pressure, but it's certainly a very deliberate sense of maintaining that engagement. And that now is coming a little bit along from posterior to anterior, with some also inferior weight to that contact. So as I get to the bottom of that initial movement through the masseter, I reach the jaw and bring that a little bit more towards the midline. So the zygomaticus, major and minor, we just think about the cheek. And this, rather than moving from the zygomatic arch down, we're going to follow now the zygomatic arch towards the midline, so working across effectively the cheek and, or the top of the cheek, and I'm going to make a contact just anterior of the ear. And again, it's bilateral, but I'm just, again, of course, drawing attention to this hand that you can see. I'm going to take up a tension, and it's not a lot of force, but it's a really deliberate attempt to get, once again, that sense of periosteum and the overlying soft tissue. And I'm moving now with my fingers on the anterior surface of the zygomatic arch, but also somewhat reaching around into the inferior surface. But just let your fingers sort of follow the contour. That's the most important part of this work. And just have a sense of lifting. And these bones have often been the recipient of some kind of trauma of their own. And by that I mean we know necks get their whiplash, but so the face also is a site of quite a lot of trauma. The source of that can vary. It can be an auto accident, also sporting injuries, domestic violence, violence in other social settings. Amazingly common in my practice, the number of people I know who've been assaulted, punched or kicked around the face, certainly can do a lot to enable the body back to some state of equilibrium and health where those sorts of traumas have taken place. So once again, the key to this is to work slowly. Okay, yeah, so one way that we can make the work a little bit more specific to the TMJ itself, so we can start exploring the tension in the tissue along the line of the zygomatic arch here. We can get our fingers in underneath that slightly. Work that inferior, work that down a little bit, work up from there. We can also bring the contact right over towards the TMJ itself and start to feel around that joint for any local tensions there. And we can just gently pick those open or persuade them open with some just fairly consistent, persistent sort of work there. And we can even take the finger, if you feel so inclined, you can take your finger right inside. I'm going to take my little finger to make sure I can take it right in. I can take that right up onto the back of the joint there from inside the ear. So I know that many of us were told never to put anything bigger in our ear than our elbow, but here we're going to break that rule and put a little finger in. And I'm going to not be pushing this way, but in slightly and then up that way. And that brings me right in behind the joint. And I can just use my finger there to start to kind of coax that myofascia out, the ligaments there. And that can feel very good where there's been a lot of dysfunction around that joint, bad position, bad glide path during opening and closing, and pain associated with that. Yeah, and so there I can really just feel very specifically onto the back of the joint surface. And that's something that I would discover as I'm going. I start perhaps with this more broad work and just working to get a nice sense of general release, and then I might also then start to, as I'm doing that work and the palpation that's involved with it, discover that I want to bring some attention specifically to the joint itself. Let's use the skull to look at that work behind the temporomandibular joint. My little finger going into the external auditory meatus, and then I'm able to work right in behind the joint there. Temporalis is quite an important muscle to work with, and there's several layers of fascia associated with it. It doesn't just lie over the temporal bone, but also over the parietals and frontal bone. And I want to, there's a couple of ways to work with that, and here's the first one, and that just works well from where I am. This is one time when I do some landing, sinking and pulling, so taking up a line of tension. So I'm just above the zygomatic arch. Of course, temporalis ducks under that arch. So landing, sinking and spreading. Okay, I have my client just open her mouth in kind of counterpoint to what I'm doing. Good, good. Yeah, so I just keep that contact, keep that line of tension in the tissue whilst she's opening her mouth. And yep, good, thank you. So that's one way to work with that. And this side-lying position is an excellent way to get into the temporalis and really all of the fascia, so we can just do some really good work all the way up the side of the head, and that's can be taken all the way up into the superior aspect of the head, so that's the galea aponeurotica, and that's often very tight, and so we can land and sink and inch our way up through the hair there, putting these little micro lines of tension into the tissue, and we can also do the same around the posterior part here. So this is how it looks. I'll just use both of my hands and I'll land, sink. Of course, there's not much tissue here, so it's easy to get to the periosteum, but I can take up a tension in the tissue, put a little sustained tension in it, and then I pick my fingers up slightly and reposition. So I'm not raking through the hair, but I'm much more doing some little increments of landing, sinking, hooking and dragging. Okay, good. Well, the galea aponeurotica quite often needs to be addressed very specifically, and one way to do that is to work with the thumbs. Well, the hands basically resting across the side of the parietal bones there. The thumbs are able to work around the crown of the head. Can start by working along either side or right over the top of the sagittal suture, just starting to move the thumbs, sinking in, moving the thumbs into the scalp slightly, and then just starting to spread that tissue. I can start to explore away from the midline, so I might start on either side of the sagittal suture, but then I would eventually start to let my thumbs move all around the top of the skull and just start to feel where the areas of binding are. And so we can just do generally a very easy, simple to perform kind of range of motion or texture pliancy test and see. And here we have nice motion, but oftentimes when you go to move the scalp, it's really bound down, and so we want to get our thumbs in there and start to mobilize that. I've got little muscles that are in the nasalis, the corrugator muscles right around where the eyebrows and the nose, that convergence zone there. There's a number of ways to work with that. A nice one is to put your one hand across the frontal bone and just a light there without overpressure, so we're not trying to provide too much force there, but a very pleasant touch if it's not done with too much effort. And just certainly not a kind of compression of the frontal bone into the table, but more a nice just taking up a hold on that, and then starting to just lift the frontal bone superiorly. So we've got this posterior settling and then slightly lifting superiorly, but none of these are done with any kind of overpressure. Just a nice sense of taking up a tension in the tissue and then the underlying feeling of also engaging with the bone. And then I'm going to use my other hand just to then lightly hang on right at the midline there. I'm going to bring my thumb and finger together and just grab the tissue there and put that tension on it. This time the tension's going inferior, so away from the other hand. And so I'd repeat that 2 to 3 times. So I've covered some work for the masseters, some work around the zygomatic arch, localizing that work to the TMJ, both from outside of the ear, and then I showed the possibility of working into the back of the joint through the ear. Then we looked at temporalis. And this, of course, can all be combined very nicely. One just flows on into the other, just isolating some of the salient structures so that you can have a good sense of how to organize your work. So temporalis, and then I showed the variation for that in side lying, then drew attention to the need to get the galea aponeurotica more mobile than it is in many people. And also just looked at the small muscles that lie around the end of the eyebrows, going across into the nose. It can hardly be overstated the value of working with the intraoral structures, and of those intraoral structures perhaps the lateral pterygoid is the most significant. However, my recommendation is that you treat this area in its totality rather than isolating a single structure and considering it to be a culprit. acting by itself. The truth is that for many people, this whole region, not just the temporomandibular joints or the face, but the whole region, including the neck and the suboccipital triangle, becomes an area of tension, and quite often considerable tension that can lead to quite a lot of distress and movement away from well-being. And approaching it in the way that we have, by working from the outside to the inside, will create a very reassuring sense of order and integration in your clients, rather than just jumping into isolated structures. First of all, work along the maxilla, putting my finger up underneath the lip and pointing up towards the cheek. And I think you'll be able to see that there's that's the nail area of this finger inside the mouth. So the pad of my finger is resting then where the gum line joins into the cheek. So I'm going to start from lateral and come medial. So there, I'm around here now. You can feel my finger over there. And I'm going to be pointing, my direction of contact is superior, but also the pad of my fingers resting against the gums. And I land, sink, let my finger rest there. Then take the pressure off slightly, move about a finger width more medially, land and sink again. And lift my finger off and move, and so on towards the midline. So there's landing, sinking, both superiorly and towards the table. And perhaps 6 sites of contact there. And this is general release. And already for many people, after doing that 2 or 3 times, there'll be a tremendous feeling of opening, relaxation through the whole side of the mouth, that whole side of the face. This is where my finger's going as I work along inside of the cheek. Pad of my fingers against the maxilla, and the tip of my fingers somewhat opening into the space, the end of the space between the soft tissue and the maxilla itself. So progressively working that line from lateral to medial. So that's it again. The inferior aspect of that is the same kind of thing. It's just that this time I'm doing it on the mandible. So I've done the maxilla, this time I'm doing the mandible. And once again I'm going to start lateral, and so I'll really point to the finger here. So this is the deep portion of the masseter now. So if I just have Marin kind of clamp her teeth together for a second and then make the masseter pop out. There it is there, and relax. Yeah, and one more time just with that. Yeah, so we can, there's the masseter and relax. And so my finger's sitting right in between the belly of the muscle and the mandible, and that puts me on the tenderness attachment of that deep portion of the masseter. And so there's once again that landing and sinking. The pad of my fingers against the bone, the tip of my fingers pointing towards the floor. And once again, I'll do that in a number of sites, working from lateral to medial, or posterior to anterior. So I'm doing this a little faster than I would do in my practice, just showing you how I'd work along systematically, feeling for that release in the fascia. These other fingers can help the jaw discover a sense of its own weight, which is not always available to people. They've been doing a lot of jaw clamping, clenching, grinding of their teeth. Then quite often the jaw has no ability to let loose and discover its sense of weight. And so these fingers here, in concert with these fingers inside the mouth, can really contribute to a sense of discovering that the jaw actually can rest away from the upper teeth. And for some people this is really, really important, that the teeth being really bound together really quite serious problem. So once again, I'd end up at the midline and I would repeat a number of times. Contact between the soft tissue and the bone as I work on the mandible, and that's also around the attachment of the deep portion of the masseter. So the lateral pterygoid, which I consider to be very significant, and so we want to get good at finding it and working with it, and this is how we go inside the mouth to get it. So I'm going to take my finger inside my model's mouth but outside the teeth, and then you could just relax your mouth. Good. And I've got now the pad of my finger, I can feel myself going from anterior to posterior, following the line of the molars now, and taking my finger between the teeth and the coronoid process of the mandible. I'm going to slide along next to the teeth, and I'll come to a bony prominence there, and that's the coronoid process of the mandible, and I'm going to work just inside of that. So between that bony prominence, which is the coronoid process, and the teeth, so the tip of my finger. Now if I can't really get through there, which is the situation here, I'm just going to ask Merrin to shift her jaw to the right slightly. And that makes a nice pocket for my finger to drop into. And I'm pointing towards the ear the whole time. So pointing towards the ear, working between the teeth and the coronoid process. And eventually you'll start to feel this very nice sensation of softening and release. And like a lot of that elevator effect, it will feel like your finger's just taken into that space without really having to force it. But nevertheless, there is some sustained pressure through the finger. So it's there, it's consistent, but it's not over pressure. I'm not trying to force that entry. Once again, I'm just down there. It's starting to happen here very nicely. Pointing towards the ear, pointing towards the table, and starting to feel that let go. That can be a contact that can be sustained for a couple of minutes. And just each time we go through a cycle of release, I just find my finger closer and closer towards the ear. Okay, so I'm not going to hang on there for 2 minutes. Take my finger out and just show you the direction. So it's in against the teeth, going in this direction from anterior to posterior, pointing towards the ear, but inside the coronoid process. Here's our access for the lateral pterygoid shown on the skull. So my little finger is outside of the teeth here, and then it goes medial of the coronoid process, and I'm still pointing past that to the external auditory meatus, and that points me right towards the lateral pterygoid. You can see my finger there pointing towards the temporomandibular joint. Secondly, we want to do the medial pterygoid. And I'm going to be working across Merrin's body so that you can see where my hand is going. And generally, I'd be working to the same side to do this release. But you'll see more clearly if I do it from the side that I'm standing. And I'll have you open your mouth again. And I'm taking my fingers this time towards inside the teeth. So unlike the lateral pterygoid, this work is done inside the teeth, and so that requires that they keep their mouth open the whole time that we're working. And I'm pointing now along the edge of the mandible, about here. So remember, I was working with the deep portion of the masseter on the outside of the jaw there. This time I'm almost adjacent, the same level on the mandible, but it's just that I'm on its medial aspect, and I'm getting to where the medial pterygoid inserts onto that. So these little muscles, lateral and medial pterygoid, exert a huge influence on the function of the jaw. That's what they're doing. And when they're hypertonic, then the result on the jaw is very detrimental. And so these are really worth tracking down. Also worth tracking down to work where you've got chronic suboccipital tension and headache, that many times that has an aspect of that. I don't want to say it's necessarily the origin of it, but one of the components of that will be coming from the tension in the jaw. So I'll point to the place where I'm getting my finger. We'll see this more clearly in a little bit when I show it on the skeleton and on the skull, but basically the medial pterygoid can be found just up under here, and that is another way to access it, but we can get much more of the muscle if we come through to that spot inside the mouth, and that's what I was just doing with my model then. The medial pterygoid, we've approached the inferior portion of it where it inserts onto the mandible, and here I've used the skull and flipped it up in such a way that you can see now through to the underside of the mandible coming up from an inferior perspective, and I'm going to point to where the medial pterygoid lies. And so that finger that works inside the mouth is working onto the edge of the medial pterygoid in this inferior portion right through here where it attaches into the mandible. And as I mentioned, it's also possible to take the finger up under there slightly and reach to it from the outside, but more can be done by working with that interior aspect that we access through the mouth. We also want to be able to treat the floor of the mouth through the mouth. So we did it by working up above superior of the hyoid bone, and this time we want to bring the detailed work inside the mouth. It's quite simple. I'll just have Marin open her mouth. I'm going to take my finger. Again, I'm working in relationship to the mandible, and I'm working to the right side here, working under the tongue, reaching back posteriorly till I feel like my finger's in a little pocket between the floor of the mouth and the tongue. I can feel my finger through here. So these two fingers are palpating each other, and I can use this finger here as a backstop to the pressure with the hand inside the mouth, and I can just, again, systematically work my way along the floor of the mouth and avoiding any overpressure as you do this, just trusting that you'll be able to get some very deep release through here if you work slowly, and just noticing that there'll be some areas, which is what I've just discovered here, some areas where the tension's more than others, and that's where I'd focus a little bit. So just spend more time working in those areas where I notice that increase in the tension. And now my inner finger, the intraoral fingers, right next to the frenula of the tongue there. So once again, I just want to state the importance of that work in child with some kind of neurological deficit or some kind of developmental delay. There's often trouble with oral motor control, and all of these intraoral releases are tremendously important. Some attention to the palatine fascia, the fascia over the hard palate, is also very helpful, and this is what that looks like. Once again, my finger is inside the mouth, and it's the palate, so of course I'm directing the contact towards the maxilla this time, so the direction of contact is superior and lateral. So there's the doming of the palate, and I'm following that dome by, and I'll bring my finger out in a moment and show the three-dimensional motion that my finger makes. So taking that back towards the pterygoid processes of the sphenoid bone, those little bumps we feel just at the back of the hard palate there. And I'd repeat that 4 or 5 times. So here's what that looks like. I'm going against the palate, and then I'm taking my finger and I'm doing a spiraling motion. So I keep pushing out and roll my finger as I go. This is highly sensory work, a highly sensory region of the body, and so it gives a lot of certainty to where the head is. So it contributes not only to the easing of local tension through that fascia, but it also gives a lot of proprioceptive certainty about where the head is spatially. And this is tremendously useful in terms of working with things like head position. And once again, head position can be very compromised in the population, the pediatric population I've referred to previously, but also in the general population as well. And part of that difficulty with head placement and control of head position is to do with a diminishment of the sensory inputs that are coming from the head. And so you'll find quite often that after doing this intraoral work, and the palate work in particular, that there'll be an immediate lengthening through the whole spine. And this can be quite visual to the practitioner, and it's a very strong felt sense for the client. With the palate, I've taken the mandible right out of here so we can see the path that my finger makes along the palate. That's passing off the hard palate and then also working back towards the soft palate. So there's the glide path there. So once again, pediatric population, it's not always possible to have a child lie passively on their back and do intraoral work or neck work or any of these things. And so I just wanted to point to a couple of possibilities. One is side lying is quite acceptable for the intraoral work. So I could just ask my young patient here to open his mouth, if you would, and I can just take my fingers inside, and this would be the work along the gum line that I did earlier with my adult model. I'm doing it a little faster, just basically showing you the territory and how I would access it. So we want to just keep seeing what's possible. How can I work with the child? Same with the pterygoids. I could take my finger inside the mouth and work. That's working towards the lateral pterygoids, pointing towards the ear. And also I can work with the medial pterygoids. So I can reach inside the mouth and work around down in here. But very useful though, if you can get your finger in, work around there underneath the base of the tongue, medial pterygoid, all of that's possible from this side lying position. And so is the palate. So this is how I'd access the palate. And just tremendously helpful in the pediatric population, all of this intraoral work. So lots of sensory stimulation, and that's probably about half of the good effect, is just helping these children that have really poor proprioception, really poor sensory motor integration through this area, helping give them some really strong sensory input so that they get a very clear sense of where my teeth are, where's my tongue, how are my teeth meeting, I know where my mouth is. And quite often you'll see very rapid changes in things like tongue placement. Drooling can be quite often diminished quite a bit, really learning in those instances, learning how, just discovering how it is that the mouth can close and that they can control the drooling. And definitely in the formation of speech you'll see those changes. Okay, thank you.